And it is now the 12 o'clock or noon hour. Thank you for being here, everyone. We appreciate your attendance at today's Maternal Health Echo, which is brought to you by the Center for Substance Use Training and Telementoring Center, or CSTAT, at Be Well, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I'm today's facilitator. To help us with attendance, we ask that you type your name, your affiliation, and email into the chat, and we thank everybody who's already done that today. To access the chat feature, click on the speech bubble icon, which is in the navigation bar of the Zoom tool toolbar, excuse me. If you're joining via phone, please email your phone number and name to cstat@uthcsa.edu. We hope that you'll join by video for the discussion portion of the latter half of the session, but no matter how you're joining us today, we're just happy that you're here to learn alongside us. We encourage everyone to unmute and share questions and comments aloud after the didactic, but we ask that you stay muted unless you're speaking until then. There is a lot of us in this space, so keeping your comments brief will allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or in our discussions. Our didactic today is on managing co-occurring health conditions in women with behavioral health conditions and will be presented by Dr. Niiang Mung, who is a clinical assistant professor in the Department of Psychiatry at the Texas Tech University Health Sciences Center. Following that, we'll discuss a case presented by Dr. Purvanshi Alag. And now we'll start with introductions, followed by didactics, announcements, the case presentation, and then open discussion. Thanks again for joining us today. And I'd like to introduce some of our Hub team members. Dr. Ruiz.
Hi, everyone. My name is Anastasia Ruiz. I'm a psychiatrist, a perinatal psychiatrist, and I am the Regional Medical Director of PeriPAM in the West Texas region. And I also supervise our resident clinic where we see perinatal patients every morning. So happy to be here.
Thank you, Dr. Ruiz. Dr. Humphrey.
Hello, everyone. I am a DNP currently out of Waco, Texas, and I've spent the last 12 years of my career doing a lot of outpatient opioid use disorder with pregnant women and homeless healthcare.
Thank you. Dr. Subrin.
Hi, good morning, everybody. My name is Joy Subrin. I'm a licensed master of social work and a doctor in behavioral health. I come to you from the OBGYN clinic at Banner UMC in Tucson, where I've been the dedicated co-located social work behavioral health provider, working in women's health, substance abuse disorder, all of the above. I'm so glad to be here sharing time with you all.
We're glad you're here as well. Dr. Alag.
Hi, I'm an addiction psychiatrist and an obesity medicine trained physician, and I'm excited to be here. And I'm very excited for Dr. Mung to be here. She was one of our residents and fellows, and today seeing her as a colleague or a co-faculty is just amazing. So welcome, Dr. Mung.
Thank you, Dr. Alag, and welcome to all of our team members. Thank you for participating in today's session. Excuse me. Dr. Mung, we're glad to have you here as a presenter, and now I'm going to hand this presentation over to you.
Thank you so much, Brenda. And yes, thank you for the warm welcome, Dr. Alag. And as you mentioned, I am a recent graduate of the Texas Tech fellowship. I did my child and adolescent psychiatry fellowship and finished up my psychiatry residency at Texas Tech as well. And so I'm honored to be able to do this today. Next slide. Okay, so I have no disclosures to speak of. All speakers, all members of the planning committee have no relevant financial relationships with a commercial interest to disclose. The views and opinions expressed by the participants and speakers attending the ECHO sessions are solely our opinions, and it does not reflect any of the positions of any of the institutions listed on the slide. And sorry, I forgot to mention the title of this presentation, which is Managing Co-occurring Health Conditions in Women with Behavioral Health Conditions. Next slide. Our learning objectives for this afternoon include a reviewing of the common physical health conditions that frequently co-occur with behavioral health disorders in the general population, in women, and in the perinatal population. We are going to work on recognizing clinical considerations that complicate care for women with co-occurring behavioral and medical conditions, including medication management and care coordination challenges. And we'll discuss evidence-based approaches for integrating behavioral health and medical care across outpatient and community settings. So, first of all, for the prevalence of physical disease among individuals with and without mental disorder, you can see in the darker shaded columns is those with mental disorders, and the lighter shaded columns is no mental disorders. And you can see that the prevalence is higher in the columns with mental health disorder for the disorders listed below. And that includes, as you can see, cancer, heart, um, stroke, diabetes. I think those are some big ones that people nowadays, suffer with. Next slide. Okay, so anxiety disorders are the most common mental health conditions among women, particularly younger and reproductive age women, accounting for 37% of cases of mental health disorders. Depression peaks between ages 40 to 59 and remains the most common clinical diagnosis in women until age 55. And after that, hypertension becomes more prevalent. So you can tell that depression is a huge thing that we can address, and it's particularly important in our perinatal and postnatal patient women. Depression also carries the highest burden of disability, representing 40% of mental disorder-related disability adjusted life years. And that just means the years of healthy life lost due to an illness or early death. Next slide. Prevalence of physical mental conditions and comorbidity. There's an estimated 6 to 13% of adults that experience co-occurring physical and mental health conditions. And women tend to have 1.5 to 2 times higher rate of combined physical, mental, multimorbidity compared with men, while men more often experience the physical only multimorbidity. Next slide. So, women with mental health disorders have significantly elevated odds of chronic physical illness compared to women without mental health disorders. As you saw in the early slide with the bars, you can see that the cardiometabolic diseases, we talked about diabetes, heart, stroke, things like that, they had higher risks. So here it says cardiometabolic diseases like hypertension, obesity, diabetes have a 2 to 3 times higher odds. Chronic pain and musculoskeletal disorders, 1.5 to 2 times higher odds. And that affects over 20% of mental women or of women with mental illness. Asthma and COPD, 1.5 to 2.6 times higher odds. The risk increases with higher mental disorder burden, rising to 4 times higher odds for women with multiple mental health conditions. And you can kind of gather that because the more mental health issues you have, they sort of compound on each other. And then with the mental health aspect, you also have a lot more of like the burden that you're carrying, not just of the stressors, but of dealing with the various visits and medication adherence and things like that. Next slide. Increased risk in perinatal population. Increased risk and prevalence. Women with chronic physical conditions have a 20% higher risk of developing mental health issues during the perinatal period, with risks slightly greater after childbirth, 25%, than during the pregnancy, which is about 12%. So about half of 52% specifically of reproductive age women report a past mental health challenge, and 20% of all, it doesn't say it here, but 20% of all perinatal patients experience anxiety or depression during their pregnancy and postpartum. And that rises to 40% among the underrepresented groups experiencing anxiety or depression during pregnancy and postpartum. The key physical mental health links are chronic physical illness, the strongest links being with diabetes, hypertension, or heart disease, migraine, and neurological disorders. And these chronic physical illnesses raise the risk of several mental health conditions that include psychotic disorders, 50% higher risk, substance use disorders, 47% higher risk, mood and anxiety disorders, almost 20% higher risk. Next slide. Perinatal population, bidirectional relationship between the physical and the mental health. So physical conditions can contribute towards the mental health. So common pregnancy postpartum issues such as fatigue, back pain, constipation, pelvic pain, wound pain, UTIs, or just delivery complications, they can increase your mental health risk. Things like PTSD, that risk nearly doubles. Pre-existing physical health problems can trigger new mental health issues as well. Pregnancy acts as a physical and emotional stressor in and of itself as well. And then you have mental health issues leading to effects in the physical health. So women who have both anxiety and depression report more physical symptoms postpartum, more postpartum physical symptoms, more than those with either condition alone. And I will attest to that because I recently gave birth and I had so much anxiety about certain aspects of birth, um, about, the well-being of the baby and how the delivery would go, tears, things like that. And I was sort of working myself up to it. Um, and I think that made not only the journey of getting to the delivery more stressful, but my perception of pain just like increased. And even with like the process of delivery, the cervical softening and things like that, it was just like my body was just so tense. And so I can attest to how stressors, anxiety prior can lead to that. And then vice versa, when you have injuries from the physical part of it, whether you have tears or whether you're recovering from a C-section or things like that, then you're much more anxious and your mood gets affected and sleep deprivation, things like that too. So protective effects of uncomplicated pregnancies. Women with uncomplicated pregnancies, they usually have no elevated mental health risks. Next slide. Medication management challenges in women across the reproductive lifespan. So there are gender differences or sex differences. Women have 1.5 to 1.7 times higher risk of adverse drug reactions due to differences in absorption, metabolism, and clearance. Our body compositions are different, and we tend to have a higher percentage of fat. Reproductive life cycle complexity. Women have the menstrual cycles, pregnancy, postpartum, menopause effect, all those things that just kind of, affect the hormones and things like that. Okay, so then pharmacokinetics, hormones in pregnancy, and then postpartum and around menses cycles alters absorptions, the distribution, metabolism, elimination. We kind of briefly talked about that. And so then you have to adjust the doses that you take during those periods. There's also, yeah, within metabolism, there's also like how much, fluid that women get when they get pregnant. They have a higher body fluid because of the increased blood volume, fluid volume. Hormonal interactions. Medications can reduce contraceptive efficacy, pregnancy, and exogenous hormones. An example is lamotrigine. Um, and so we have to be mindful of those medications that alter drug levels. And then a clinical implication for this is you want to make sure you have close monitoring of your patients, therapeutic drug monitoring, and an individualized dosing that's essential to optimize safety and efficacy because each person will have, um, pregnancy aside, and other hormonal like postpartum or menstrual cycles aside, we all have our own metabolic profile. And so then with these complications added onto it, we just have to be much more vigilant about monitoring our patients during these sensitive times. Next slide. Okay, so then how do we coordinate care? We have several system level barriers. OB-GYNs often serve as a first line for both mental and physical health with limitation in time and resources. They have a lot of patients they have to see, and there are a lot of issues that they have to deal with because during the duration of the pregnancy, the OB-GYNs are the ones that the women see the most. Um, when patients have multiple clinicians, psychiatry, primary care, OB-GYN, subspecialists, that can be overwhelming, and you could have a problem with the integration of information and tests and medication adjustments and whatever information is passed on to the patient. We can have a limitation in integrating all that. And that can be from EMR integration, staffing limitation, workflow challenges, or even geographic barriers too. I've seen patients who, especially in the Lubbock area, we have patients coming from New Mexico, and so they have their primary care in New Mexico, but then they'll see OB-GYN in Lubbock and see psychiatry in Lubbock. And so there's also geographic barriers as well. Polypharmacy risks, um, multiple physical mental health conditions, and multiple prescribers can lead to the risk of polypharmacy. And again, if not everything is being communicated clearly, sometimes you don't know what the other provider prescribed just because lack of clear communication. And so that can increase interactions and adverse side effects, and that can present challenges to balance treatment with the benefits and the risks of the treatment. Diagnostic barriers, overlapping mental and physical health symptoms complicate recognition and diagnostic clarity. Patient level barriers include difficulty with medication adherence, especially the more specialists they see, the more medications they're on, and maintaining healthy behaviors. Transportation is an issue, financial constraints is an issue, and limited engagement in care can be an issue as well. Next slide. So what are some evidence-based models for integrating behavioral health and medical care? One is collaborative care model. And so it's team-based. It combines the OB-GYN with a psychiatric consultant. It's adaptable and reimbursed by insurers. It's effective for depression, anxiety, perinatal depression, substance use, and the impact can double the effectiveness of depression treatment. Primary care behavioral health is the next one, behavioral health embedded in medical care that can reduce stigma and improve access to care. A lot of patients may not want to deal with having to see another provider, and they just prefer to have everything done by their primary care provider because they already trust that person and they already have built rapport. And so sometimes even if they're referred out, they just kind of don't want to go. And so having that embedded can really help with the access to care. Patient preference, most prenatal, we just talked about that. Most prenatal women want behavioral health support from their primary care clinician. About 55.6% prefer in-clinic care, and then 10% really have no preference or are not really sure. Barriers include limited time, and that's the majority of the barrier, and then perceived need and availability. Impact with this, it drastically improved access to mental health care. Measurement-based care. This is where we use validated tools to track symptoms and guide treatment decisions, tools like the GAD-7, PHQ-9. And the impact of that is improved remission rates up to 75%. Next slide. So the evidence-based perinatal mental health support that we have is our PeriPan and BeWell Texas. So PeriPan, our perinatal psychiatry access network, what it is a statewide clinician-to-clinician consultation program for perinatal mental health. And it helps by providing real-time guidance on diagnosis, treatment, medication management, and it supports integrated care, like we talked about on the first column in the previous slide, symptom monitoring, and individualized treatment planning. It offers referrals, resources, and CME training for clinicians, free for clinicians, increasing access to high-quality care. And the people that benefit are the clinicians. They gain confidence and expertise. Pregnant postpartum women, they receive timely evidence-based care. And I want to go a little bit into the referrals that with the referrals, when the clinicians refer their patients to the PeriPan team for a more in-depth, or if the PeriPan consultant and the clinician both agree that the patient should be more for better fitted for a direct referral and direct consultation with our team, they can get free evaluation. Just that one evaluation is free, and that tends to be done fairly quickly. It's faster than referring to them to an outside psychiatrist, and they can get a full evaluation, and that evaluation will be and recommendations will be sent back to the providing OB-GYN or whoever, primary care provider, whoever. And and then after that, you can continue to call for these, real-time guidance on diagnosis, treatment, any adjustment in medications and things like that. So it's a great program. So that's PeriPan. Next, the other one is BeWell Texas. What it is a statewide initiative supporting men and women with substance use disorder, co-occurring mental health conditions. How it helps is it provides psychiatric evaluations, counseling, med management, recovery support. It integrates the behavioral health into the medical care to increase access and to reduce stigma. The people that would benefit from this would be people with substance use disorder or mental health needs, and the clinicians who are treating these people. Next slide. This is the list of the references. And that's it. And I want to also thank Dr. Ruiz for her help with this, putting together this slide. I really appreciate her helping me in my first time presenting for ECHO. And thank you all for your attention.
Thank you, Dr. Mung, for the presentation. You did a great job. And so now I'd like to open this up to for questions. There haven't been any that have come in during the presentation, but I do want to open up both the chat and the echo for questions or even comments that participants may have.
I see one question I can't answer in the chat. It says, how is BeWell Texas financed?
Okay, I'm gonna have to invite someone to step in on that. That is above my pay grade.
I don't know if we have any BeWell admin on here.
I can help answer a little bit because StarCare is working. Apparently, StarCare where I work is under BeWell Texas, is my understanding, because of all the funding that's been going on. So it sounds like BeWell Texas is a flagship kind of initiative with the BeWell Institute and Substance Use Related Disorder at UD Health San Antonio. But to answer the question, it is primarily funded state and federal public funding. So the grant support for operations, services, and expansion of substance use disorder treatment across Texas. So federal and state, if that answers the question. It's a mix of both. And the main funding source comes from Texas Human Health, I guess, Service Commission. And then that's one of the biggest ones, the Human Service Commission. That's all I know. Sorry, I don't have a lot of information, but that's all I know so far. I've learned so far.
Yes, thank you, Dr. Alog, for providing that. And thank you, Dr. DeReese, for your question. I see another question here from Andrea Albrecht. Is there a program to connect women who specifically may be carrying a pregnancy that if the laws in Texas were different, they may choose not to carry?
And wait, Andrea, are you able to unmute to elaborate a little bit?
Yeah, so I work for one of the insurance companies with inpatient behavioral health, and it kind of seems we haven't been tracking the data, which is unfortunate, but we've had like a uptick in admissions, and one of the triggers is they are pregnant and they don't want to be pregnant. Is there any resource that you would recommend connecting them with? Because obviously, with the state law changes, they are going to have the babies.
I've heard of something. I'm going to go ahead and answer for a little bit of no, but there's something known as Thriving Texas Families, and that's a state-funded program. So that's one of, I mean, you probably want to look it up. I don't know a whole lot about it, but Thriving Texas Families is one. And then a lot of resource centers and pregnancy care centers might also have that information. And then adoption support programs are also very helpful if a woman decides not to carry the baby to term, and they can kind of help with adoption planning and support. But that's pretty much it I know. I hope that answers some of it.
I was
All
thinking
right.
along the same lines. Oh, sorry.
Oh, thanks. I was thinking more kind of like with the lines of, they're not accepting the changes in their body well and what's happening to them physically, in addition to like, that whole adoption or not adoption thing.
So you're talking about the mental health component, like coping
Correct.
through.
Correct. The coping.
Yeah. I mean, thanks for clarifying. I think we're all walking in those two worlds, but I'm glad you clarified. I mean, I think all of us would offer that, empathetic support in person and then see if we could branch, create a connection for that patient to get involved in any of the behavioral health networks that are in the city she lives in. If she feels ready for that, there's also some more confidential supports like the Mama Line or maybe anything through postpartum, which I think is now called Peripartum Support International because it's for antepartum and postpartum women, just to have a safe. Oh, you can't hear me? To have a safe place to talk.
Yes, we can hear you.
Oh, okay. Okay. So, oh, I'm coming in and out. Oh no. Well, that was the end of my statement. I'll write it in the chat.
Thank you, Dr. Subrin. Kimberly Hayes asked, in response, would adoption services help with Catholic charities, unplanned and desire to give up parenting? Dr. Laura Young said it would also depend on where she's located. Not sure if that Dr. Subrin's comment helped with the question. Thank you, Dr. Subrin. That HRSA Mama Line for emotional support through this process of change.
Yeah, and it's Dr. Ruiz here. Hi. There's another amazing resource too. It's the National Maternal Mental Health Hotline, and it's 24/7 hotline. And it covers the whole United States. So I would think that they would have great resources for women in Texas. For me specifically, if this has come in my clinic in the past, and these are common for several reasons. And next, on the next webinar, we also talk about cases where people have severe like nausea from pregnancy, and sometimes women do have a hard time, and sometimes that includes wanting to terminate the pregnancy. And so our role is to really navigate, our patients, help them decide what is the barrier to their mental health care and prioritize on that. And so it's not a straightforward answer, and it's going to be an individual response, but that National Maternal Mental Health Hotline, they're wonderful because they're up to date. It's staffed by a social worker. So if it's a number specifically for families and their patients, and they can call up and see if there's any additional support, whether that's in the state of Texas or outside.
Thank you, Dr. Ruiz, and I see that Dr. Subrin is dropping a lot of that information in the chat as well. We have time, just a few more moments for additional questions. One from Sandra. Sandra, if you'd like to unmute your mic and ask that, I invite you to do so.
Okay, hi. Can you hear me?
Yes, we can.
Thank you. There was a slide that was comparing the 3 different approaches to care and what was the percentage of the, better outcomes for the client. The third option, I can't remember the acronym. Can you explain what that is and what are some examples of that type of care?
Can we go back like 3 slides? I think it might be 3.
Yeah, I think it's about right. Thank you.
Slide number 12, I think, is what you're referring to.
Mm-hmm.
So Leo, are you able to pull that slide up?
And while we're waiting for that slide, I can chime in here. It's a measurement-based care. And for those 3 models, we encourage incorporation of all 3 because they are different focuses. Measurement-based care is utilizing screening forms and screening tools to track a patient's progress over time.
So an example of that would be, for instance, when the patient first comes in for depression and or anxiety, like we'll take whatever tool. So like PHQ-9 for depression, say, they come in and they have a certain score, and then you start treatment for it. And after, say, a month, you see them again, you get the score again. And depending on where the score is, you can say, oh, this treatment is working, the scores are decreasing, or you can say, oh, it's either increasing or staying the same. What else can we do? Do we need to, increase doses? Do we say this is not as helpful and try a different medication or even a different route, add something else to it? But it is also, a lot of them are screening questionnaires, and so you have to take it all with a grain of salt, and you have to incorporate it with your clinical interview and the history you're getting from the patient and other things. But this is one way that we can try to be objective in our care, because there isn't, as my program directors and trainers had told me, there isn't like a blood test you can do to like measure. And so we have this to try to have an objective way to measure the continuity of care and seeing how that progresses. Because you and I both know our memories tend to fade, and we can say, oh, wait, was it better last week or 2 months ago or 1 month? And so at least when we have this, we have some sort of concrete numbers that we can use to track, and we can just say, hey, 3 months ago it went up or down when we did this, and have some sort of comparison.
Can I
I'll
add
add to that? I have found that I think one of the reasons it can improve remission, for when you're able to track it, but also I think patients sometimes get discouraged and feel like they're not getting better. But when you kind of have a black and white number to compare to, it's like, oh, wow, I am improving. And so it's kind of like self-motivating in a sense. They see the progress that they're making, and it builds on itself.
Could I add on to that, the question to begin with? So I would make the assumption that with collaborative care or in primary care, those screening tools are probably being used and they would be part of record. So, is it not? Just saying.
I think, and other people feel free to chime in, but from what I've seen, sometimes it's added as like the initial, but it's not always regular. And this is saying we would sort of have it as part of the regular check-in so we can track it over months rather than like here's at the beginning and like here's like a year later, you know.
Okay. Well, I'm just going to add one more thing and put a shout out to Nurse Family Partnership on this. This is exactly what the nurses do. Although we cannot treat, we can do provide some therapies as far as, like meditation and, just increasing their confidence and things like that. But of course, referring them out to the appropriate medical provider or professional. But for a note of that, if a client would be in a nurse family partnership area, I encourage referring them. And because then the nurse would also be collaborating with the providing physician these results. Because she cannot treat, she would certainly update us because we do that routinely. Just saying.
All of this discussion and all of the comments that are coming into the chat, I encourage everyone to continue sharing questions and responding to each other's questions and sharing recommendations and successes that are in the chat. With just to preserve our time, we would like to move on to our case presentation today. Dr. Alog is our case presenter, and I welcome you and ask that you walk us through this case.
I'm not hearing anything if
Not
anybody's
either.
speaking. Okay.
Sorry, can you hear me now?
Yes,
There we go. Yes.
Sounds great. So this was a 32-year-old female, Hispanic. Her sexual orientation, she was heterosexual. Some of the cultural considerations I wanted to mention here was limited access to specialty care. So that could be addiction, or that could be child, or whatever that is. And then stigma around mental health and substance use. She did experience symptoms of depression. She experienced symptoms of anxiety. And some of the other symptoms that she reported were emotional eating, body image distress, and poor sleep. Patient also reported, in terms of specific symptoms, is persistent low mood, fatigue, guilt related to weight gain and substance use, concerns for relapse, significant anxiety around pregnancy outcomes and parenting capacity. History of trauma was pretty significant as well. Substance use, she was vaping every day and she had been trying to cut down. Alcohol use, it was binge drinking prior to pregnancies, about 6 to 8 drinks per night. She had been abstinent since she found out she was pregnant. Cannabis use was pretty intermittent again prior to she found out she was pregnant. No other substance use. Her primary substance use disorder diagnosis was alcohol use disorder moderate. Nicotine use, because it wasn't still very clear how much she was using, so we couldn't really define it to be a disorder. In terms of primary mental health diagnosis was major depressive disorder, and then the secondary was generalized anxiety disorder. She had not been in counseling services in the past, but most recently she had been doing weekly telehealth CBT. And then she had not been on medication, in the past, and she was considering to be on medications for alcohol use disorder and depression, but she was very concerned about her pregnancy. And then she started to actually take the medication, which I'll just mention about in a minute. Inpatient services were never sought, so no mental health hospitalizations. She also actually started enrolling herself in attending the online women-only recovery group, which we found was very helpful. The risk reduction services that were offered to her were alcohol relapse prevention counseling, smoking cessation counseling, nutritional counseling, which is focused on non-restrictive approach. Obviously, she was pregnant. And education on pregnancy safe weight management. PDMP was looked through. There were no concerns for safety in terms of there were no controlled medications that were being prescribed to her. Most recently, she was started on sertraline, and it was increased to up to 100 milligrams every day for depression and anxiety. And then she was also on the prenatal vitamins. No surgical history. Additional medical comorbidities were her BMI was 38, pre-diabetic, and then there was history of gestational hypertension in prior pregnancies. So the question that I had for all of you here, thinking about the ideas and how we can work on this case is, what strategies do you think are most effective for preventing alcohol relapse during pregnancy and the early postpartum period in patients with co-occurring depression, anxiety, and obesity? That's one of the first things, right? There's alcohol relapse concerns. Obviously, during pregnancy, it's pretty stressful. After pregnancy, it's really stressful. So what kind of effective strategies could we utilize? And the second is, how could we actually treat it? The pharmacological aspect is also really important to be considered for alcohol use disorder, for depression, and obviously the metabolic risk, the additional weight gain that individuals or pregnant females would actually gain. And obviously, you want to keep in mind, they want to balance the maternal benefits and fetal safety.
Dr. Locke, I had a couple of questions. One, I was curious how far along she is in her pregnancy right now. And then second, if she's taken medications in the past for alcohol use disorder that were helpful. And then third, is she currently having alcohol cravings, or have those gotten better once her depression's improved with the sertraline?
All are great questions. Thanks. So she's in second trimester. To be very honest with you, I do not remember the weeks, but she's in second trimester. And then she currently is taking medication. Was that your question? So she's been on sertraline, but she's not been on alcohol use disorder medications ever.
She hasn't been on like naloxone or naltrexone or a camprosate or anything.
Yes, I know she's not been on that before. And there was another question you had. I'm sorry, I forgot.
I was curious if she's currently having alcohol cravings and if that's improved at all on the sertraline, if her depression's getting better and her alcohol cravings are simultaneously improving.
So I think when we typically asked if she did have alcohol cravings, she would say, well, no. But then if you deep dive into it and ask her more, she would say, well, when my depression gets worse, my anxiety gets worse, I kind of get very anxious, things get worse. So I end up actually thinking about alcohol. So it was never a yes for alcohol cravings, but I mean, if you kind of hear her, it is pretty clear she does have cravings for alcohol because that's really her way of escaping all the stress, anxiety, depression, and all of that. So I would say yes, she did have cravings.
We have a great question from one of our learners in our community. Andrea, would you like to unmute and ask that aloud?
Sure. What helped her stay sober in her past pregnancies?
She had a supportive partner at the time when she was pregnant in the past, so that was really positive for her. But this pregnancy, apparently they had a lot of relationship issues, and then she was just by herself. So supportive partner was one of the big things for her. And the partner with her had been sober for a very long time.
I was curious, and maybe it's in there and I missed it, how many other children she has and if they live at home with her.
She's had 2 before.
2, okay. Is there anyone that lives at home with her?
No, the custodies have been taken away. Okay. And she does not get to see the kids.
You mentioned that she is receiving counseling services?
Yes.
Okay. Yeah, I was just curious if she's if she's working around the guilt and the shame that she may be carrying around not having her children and possibly using under the influence, because that guilt and that shame can, really cause, especially with moms, right? Also, there's recovery support groups for food disorders. There's a lot of virtual ones also where someone could go and just listen in to see if she's tying into the emotional eating, not only that she's pregnant, what she needs to eat, right? But also like after she has the baby, is compulsive eating an issue for her, because there's a lot of support groups that can help her, where she doesn't feel alone. Because one that has a compulsive overeating has compulsive overeating, it's a disease of isolation, and it just, the shame that comes around that, you don't let people see how you eat. Just there's so much more there, right? And we know that addiction changes its face, right? When somebody doesn't use that, it may be, food, sex, gambling, and a lot of times for a lot of people in early recovery, it is food.
Right. I think one of the things you really said was interesting is a disease isolation. So like kind of that's very comforting. And the patient did say it was really comforting to eat at night. So a lot of compulsive behavior of eating, and sounds like it was almost soothing um to eat at night. Only mostly like she would say I starve all day, but then I eat at night. It's very comforting. And I think it was almost sound like binge eating disorder, but we weren't very certain about it. Now she's also pregnant, so it's hard to diagnose someone when you're pregnant. But it's really helpful to hear the recovery support groups would be very helpful because she's in weekly. She barely just started the group, so it's hard to say if it's very helpful. She's still finding if she's going to connect with this person who she's going to for CBT. I'm not sure if CBT is very ideal for her at this point, or she would need something more trauma focused. But I think something is better than nothing. But that's actually pretty amazing to hear. So thanks for that.
Oh, also, we have support. We have groups on Wednesday and Thursday that are virtual that anybody in Texas can jump into. Don't have to be enrolled into our program. I can put them in the chat, and anybody can pass it along. Anybody can come. It's a recovery support group on Wednesdays from 3:15 to 5 with our coaches and with our icon heroes, UT Health in Houston. And then we do an educational group on Thursday. The counselors do a group on Thursdays.
Oh, that'll be amazing. And
I'll
that's
put that in the chat.
Thanks. Is
Yes,
that
thank you for sharing that resource in the chat. We have a few comments and questions in the chat as well. Want to allow our learners from our community to unmute and ask those aloud, provide those aloud.
So is that a question from Joy or from someone else?
We have
above me. Yeah.
Yes, from Andrea again.
Okay, if she lost custody of her kids, has health issues related to pregnancy, support concerns, and cravings, she might meet criteria for substance RTC. I'm not sure what RTC is.
Residential treatment center.
Oh, okay. Okay, great.
I know Nexus in Texas is really good. They do a lot of pregnant and postpartum women. So
thanks for sharing that resource. I actually did rotate through Nexus when I was doing my fellowship at UT Southwestern. So it's a great place. I think she would really benefit from Nexus. She doesn't have custody of her kids is one. I don't think she's focused on getting those kids back. I think she's really protective about this pregnancy because she's wanting to be sober. We did try and provide her with some resources, not necessarily Nexus, but she's not wanting to leave Lubbock. And Lubbock has resources, but I'm not very proud of the resources we have here. It's okay-ish, but that's helpful. Her relationship with food is, it's comforting for her. It actually helps her to feel better when she eats, but then she eventually feels pretty guilty. So it almost seems like there's food addiction as well.
Yeah.
But she doesn't have any purging behaviors or use of laxatives and all of that eventually, but she feels pretty guilty of eating the food that she does, just to kind of comfort herself. A lot of sweet cravings is what she reports. A lot of junk food is what she eats, even though she's pregnant. In the place where she lives, she doesn't have transportation, so the food insecurity is pretty significant. Like she can't really go and buy, and finances is a big problem as well for her.
I was guessing you would say something like that. So when I first read this case, I immediately started thinking like, what is her routine? And now even more concise, what's the nighttime routine when those real issues spark? And I'm not a nutritionist, but there's like the My Plate app. Maybe there's some swaps we could teach her of what could be sweet and healthy during pregnancy. There's things like WIC and food delivery programs that can be helpful to get those apples and cinnamon delivered instead of, it's oftentimes just removing some of the shame and putting in a new option, like instead of that, maybe one time this week you had this, and that's progress. And I love the idea of any sort of online support group for substance use or, food cravings. But I'd be thinking about her nighttime routine.
I was thinking, so I know to address your questions about pharmacology. It sounds like she's got some cravings, but maybe they're not crazy intense. I don't know. The two meds we use the most for that, like the camprosate and the naltrexone, are questionable during pregnancy. Camprosate we typically avoid. I don't know what you typically do. The naltrexone we occasionally do, but discussing, is that something she wants to start postpartum? Is she planning on breastfeeding? The other medication that I think I would have on my list would be Wellbutrin, just because it's more weight neutral or sometimes can help with weight loss if that's a concern. But if she's stable on sertraline, it's like, don't want to rock the boat postpartum. I don't know. So those are kind of my thoughts on medication. Of course, just being super careful with pregnancy, but also just exercise. I wouldn't recommend she start a brand new exercise routine right now, but planning ahead for postpartum, if food in the evening is something she considers comforting, but she feels guilt, maybe figuring out some mommy and me exercise program or something she can do where that's kind of comforting, but also bonding for her and baby and makes her feel healthy. And so trying to start planning those things now so that postpartum she has a plan in place that she can feel good about.
That's great. So I would agree with you. The camprosate, I would not do it, obviously, because of reasons. Naltrexone, again, if you see, I mean, there are just few literature studies, observational studies out there with naltrexone. If it does outweigh the benefits over the risks, versus the patient continues to drink, I would obviously encourage them to be on naltrexone because the side effects are way less versus someone continues to drink. And if it's been beneficial, if they're on it, I would just keep them on it. So naltrexone I would still do it, but not camprosate, absolutely not, like you mentioned. I might also consider gabapentin for them when they're pregnant. It's not a complete contraindication. I mean, people use it all the time. It can help with alcohol cravings as well. It can help with anxiety, help with sleep, which also can be a problem that she ends up eating. The stress is pretty significant as well. So I would probably still encourage them to take, prescribe gabapentin if they need it. Again, if not, I would not want to do alcohol and gabapentin together if she starts to drink back again during pregnancy or after. But I would definitely, like you mentioned about the breastfeeding is really helpful if she wants to breastfeed, how she wants to do it, just pump, or like, obviously in either case, we need to know what medications she's going to be on and so forth. But that's very helpful. And I might even consider during pregnancy metformin for her, which would be very helpful. I don't want her to have diabetes while she's pregnant. So I might even consider that. It's going to probably be very hard with the BMI of 38 or whatever I said, for her to be able to lose all that weight, because sometimes your genetic predisposition and sometimes, people, the metabolism just slows down so bad that's very hard to even cut down on diet. You might cut down on diet, it still might not help. So I would probably consider metformin and things like insulin, but absolutely not the GLP-1 agonists while she's pregnant.
Diana dropped those links for those peer groups into the chat. Thank you for that, Diana. And then we also have a comment from Rue Todd about the Nexus group. Would you like to unmute and share your comment and your experiences with that group?
Well, it sounds like sorry, is someone going to say that? I can just probably read it. It looks like in the area, and I was one of those who actually was able to witness when I was a fellow there. They do have mothers group in person every Tuesday at 11 o'clock. I'm not certain about the time as well, so they're not certain on the time, but it looks like they do have a lot of community-based activities. And if transportation is an issue, they can also kind of find some recovery peer people around, which are probably in the same situation. They can help out as well. So thank you for that information. Okay, great.
Dr. Subrin, you talk about the Calm app or the Insight Timer, and Dina adds mindfulness eating strategies may be helpful as well. Dina, do you want to talk to us a little bit about those strategies?
You can so you can teach patients to learn how to take smaller bites, or take as many bites out of maybe like a little nut, a grape, or some kind of small piece of fruit or nut, so that way they learn to like focus on all the sensory aspects of the eating, um, and get them to really savor the food that they're eating, and then get them to apply that to a meal, or a bigger snack, but starting small with just like one piece of food.
Great. So
Also cutting out, cutting out any like TV or anything else, and just focusing on the eating and nothing else going on.
So mindfulness eating. That's great. Okay, great. Thanks for sharing that.
We have additional comments coming in through the chat, and I appreciate and encourage you to continue sharing those comments and those questions. Dr. Alog, if you would review, there's a couple of questions and then additional suggestions and strategies and resources that are available there. But just to protect everyone's time, we're going to go back to our announcements. We appreciate you, Dr. Alog, for providing this case for discussion. We had a wonderful, robust discussion happening here. If you have additional comments or questions, you can type those into the chat. And again, access the chat feature by clicking on the speech bubble icon in the Zoom toolbar. And as we move to announcements, just a reminder that to receive credit for today's session, participants must have an active account with the Texas Tech University Health Sciences Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that's provided in the chat, or on the instructions on how to receive credit document that's been posted to the Content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation. For specific questions about CME credits, please email or call the TTU HSC CME office. You can scan the QR code that's on the screen right now, or you can click on the link that's dropped into the chat to complete the session evaluation, which will be available until 11:59 p.m. on March 2nd. If you already have your account set up with the TTU HSC CME office, you can use the text in attendance feature with the code 39940. The text code is only available until 11:59 p.m. today. Do you have a difficult case that you or your team have encountered? Well, let's tackle it together by bringing your challenge or complex case to the Maternal Health Echo. You'll get support from a team of experts and fellow providers. There's no need to prepare a formal presentation. We'll provide you with a case form to fill out to assist with your case presentation. You can email us at cstat@uthscsa.edu to present a case. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at cstat.uthscsa.edu/contact us, and we'll be pleased to help you. And registration is now open for the 2026 Texas Substance Use Symposium. Join us March 2nd and 3rd at the Henry B. Gonzalez Convention Center in San Antonio, Texas, for 2 days of learning, collaboration, and connection. To learn more, please visit texas.org/registration. And you can partner with Texas to showcase your organization, support statewide collaboration, and connect with substance use professionals across Texas. For more details on sponsorship and exhibitor opportunities, please contact texas@uthscsa.edu or visit the page that's listed on the slide right now. And with that, I'll pass this presentation on to Jen Erdigy with PeriPan Program, who has a few announcements for you.
Thank you, Brenda. Just going to provide a real brief overview of our Texas Perinatal Psychiatry Access Network, PeriPan, and just a recap of what Dr. Mung said earlier. So we are designed for clinicians who see pregnant and postpartum women, and PeriPan was created to address the maternal mental health crisis. So mental health conditions are the most common complications of pregnancy and childbirth. They affect 1 in 5 perinatal women and ranking among the leading causes of pregnancy-related deaths. So a lack of access to care and provider shortages further compound this problem. So as you see on the screen, PeriPan has 4 major components. We provide clinical guidance to help you with either a single case or enhance your mental health practice as a whole. Next slide. So PeriPan is anchored by 12 regional medical schools and health-related institutions across Texas. As you can see on this map, you can sign up really easy and you'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes or at a callback time that you choose. Anyone in your office can call to start the consult or request. And each region does have their own unique texting number, which we will provide to you at sign up. And you can call the number on the screen to enroll within 5 minutes. Next slide. Webinars. We'd love for you to join us for our PeriPan webinar series. They're held on the 3rd Tuesday of each month at noon Central Time. We're excited to share that we launched a fresh lineup of sessions last month. So these webinars do complement the ECHO series by offering a deeper clinical insights and opportunities to learn directly from experts in the field. And on the screen, you're just going to find a list of upcoming topics and dates. So be sure to register, stay informed, strengthen your skills, and continue building confidence in perinatal mental care. Next slide should be echoes. So this is just a list of the topics and dates for our upcoming echoes. They're held on the 1st Tuesday of the month. We invite you to join in these future sessions to continue learning about important topics. We will be sending out the 2026 topics here shortly. And then I'll hand it back to you, Brenda.
Thank you, Jen. And before we wrap up, I welcome Dr. Ruiz to provide our session summary and case recommendations.
Wonderful. Thank you all for being here. And to summarize, the most important learning point today is that physical and mental health in perinatal women are deeply interconnected. And recognizing this bidirectional relationship is essential. We want to remember that mental health care is part of healthcare.
Thank you, Dr. Ruiz, and thank you for joining today's Maternal Health Echo. And we extend our appreciation to Drs. Mung and Alog for their parts in today's presentation as well. As a reminder, to earn CME credits, please complete the evaluation using the link that has been provided in the chat. If you have a case or scenario you would like to share, please email the CSTAT team at cstat@uthcsa.edu. We look forward to seeing all of you at our next session on Tuesday, March 10th at 12 p.m. Central Standard Time. Have a great rest of your day, everyone. Thanks for joining. Bye-bye.
Thank you, everybody.